I want to welcome everyone to our latest Next Practices weekly Thursday call. That was some high energy music to get us started, some late career Elvis, as Kevin Martin quipped, better to hear late career Elvis than to see him. So welcome everyone to Next Practices Weekly from I4CP. My name's Tom Stone. I'm a senior research analyst here at I4CP. That was not my song selection. I believe it was the selection of our special guest today, who we'll introduce in just a little bit. If you're not familiar with these calls, if you're not familiar with I4CP, we are the Institute for Corporate Productivity. I certainly see many friendly faces and names that have been with us over the many weeks that we've been doing these calls. But if you're new to the call, welcome. We are a human capital research firm. We discover the people practices that drive high performance. We do that through our quantitative studies by trying to tease out what high-performing organizations do differently than low performers. And we define that by looking at revenue growth, market share, profitability, and customer satisfaction. We try and look at what the top quartile, roughly, of companies do differently on a wide range of topics across human capital, human resources research. Of course, we provide a lot more value than just the research. The peer communities have grown tremendously over the years and now represent a huge additional value for our member companies. We are a member-driven organization. You see here just a small sample of I4CP member organizations. They really span across all industries, different company sizes, from the very large, like Amazon, Accenture, and others, to maybe some that are a bit smaller, but again, spanning across all industry types, sectors, and indeed globally as well. A couple of other quick reminders. We recently did a study, our second major study on culture, just in a matter of a few years. Culture fitness, the healthy habits of high performance organizations. We just rolled out the results in the major report for this for our members just a few weeks ago. You can go to go.i4cp.com/culture fitness and get all the information on this great new study there. And if you missed the session 2 weeks ago, I believe it was February 16th, we had Kevin Oakes and Catherine Brecken from I4CP presenting some of the key findings from this study. That is a publicly available webinar that was part of this Thursday Next Practices Weekly series. So you can go to our website and find the recording of that, as well as plenty of notes. And the other reminder, still coming up, and we're now in the month of March, and late this month is our Next Practices Now conference, March 27th through the 30th, held each year in Scottsdale, Arizona. We were back there last year after having to take a couple years off due to COVID. It was a great time last year, but this year is going to be even better. We're already seeing record-setting numbers of participants registered, but it's not too late to register. Just go to i4cp.com/conference. You see here just some of the lineup of outstanding speakers we have at the conference, and it's really a good time for all HR leaders that want to participate. We're also seeing an uptick this year in HR leaders that are bringing some of their teams, sometimes 5, 10, even more of their senior leadership teams for development purposes. We've always had that as part of the conference, but at least I'm anecdotally seeing more of that in the registration numbers so far. Just a reminder that this call series is every Thursday. You see some of the great guests and topics we'll have coming up. We'll be taking the 30th of March off for the conference, but the following 3 weeks coming up, we've got folks from Toro Company, Ecolab, and Getty Images, Margot King, Paul Langlois, Marie Potter, and Nicole Underwood will be our guests in upcoming weeks. Again, I'm Tom Stone, Senior Research Analyst here at I4CP, and I want to welcome and introduce my co-host this week, which is our Chief Research Officer and also my boss, Mr. Kevin Martin. Good morning, Kevin.
Hey, Tom. Good to see you as always. Thanks for having me.
Yeah, good to be with you. Great to have different voices on these calls week to week. And without any further ado, I'm going to turn things over to you, Kevin, to introduce our special guest today.
Well, I am particularly thrilled to have been asked to be a guest on this particular call, Tom, because I'm a huge fan of Greg Tills. Greg, I got to know when he served for several years on our Chief HR Officer board that I'm the exec sponsor of. And Greg is always took me as someone who was constantly not only challenging the way he was thinking, but challenging the organization that he's a part of and the way they not only think, but the way they operate. And so I'm just thrilled that we have an opportunity to showcase Greg and just his mindset and his strategic nature here. And he'll tell you about Providence, et cetera. But with that, Greg, welcome to the hot seat here.
This isn't a hot seat. You guys are my friends, and so are all the participants on the call today. I'm incredibly excited about sharing a little bit about what we've learned in the past couple of years and what we're thinking about, hoping to bring some of the theory and great ideas that we talk about a lot into practice for folks. And hopefully in chat, we'll also hear from others. I see lots of great folks from different industries and a lot of brothers and sisters from my own industry in healthcare who are dealing with a lot of the same challenges and probably have innovative solutions I'd love to learn from as well. So thanks so much for having me today.
Oh, it's an absolute pleasure. And you know, you provided some slides here, Greg, really the way we love to, the way anyone should ever look at any issue is what's the macro picture? What's driving the situation here? And you're going to paint this really vividly for everyone. So why don't you start out with a little bit about Providence Health, and then you could start sharing about, you know, what's driving the need for all this change that you're driving.
Fantastic. Yeah, thanks for the opportunity. We'll start with a macro picture and then talk really specifically about our strategy and some of the things that we're doing to kick off the presentation. Don't worry, even though I'm kind of known for talking fast and using 300 slides in my presentations, I think we have 3 or 4. So plenty of time for conversations and Q&A. This is a little bit about Providence, and I just put this up there because I'm so grateful to be part of an organization that was founded by a group of women almost 170 years ago that still, if we are a for-profit company, is in the Fortune 150. I think that there might be like, 3 others that fit 1 or 2 of those criteria. Providence is one of the biggest health systems in the country. Some of you may have never heard of it because most of our ministries are on the West Coast, but we have 120,000 caregivers, 52 hospitals, over 1,000 clinics at this point. And we serve over 1.9 million covered lives. We give almost $2 billion back in community benefit every year to folks who can't afford care or to preventative health. And our mission is really about helping everybody in our communities, especially with a special attention to those who are poor and vulnerable. And we do a lot of work on the social determinants of health, health equity, with a keen focus on that community. So I thought I'd start on the next chart talking a little bit about the overall macroeconomic trends. Everybody on the call probably knows what this looks like, but some of you might not know specifically what it looks like for healthcare, which has an even more dire dynamic than some of you might be facing in your industries. On the left-hand chart, these are some generic macroeconomic trends. You probably saw the most recent jobs report in January. Despite all the analysts predicting significant decreasing job gains, we had a job gain in January that blew past expectations, over 517,000 jobs added. CNN said that this was shocking, astonishing, remarkable. We're running out of adjectives to describe how stunning this job report was. Despite all the headlines that you see in the newspapers, this is what we talk about a lot internally, separations remained little changed. We had about 4.1 million separations in December. It was about the same as that in January. And in 2022, overall, the US saw 76 million hires, over 50 million quits, which both broke records at about 20% higher than a normal run rate in 2019. The workforce challenges are not going to stop this year, despite, again, some of the headlines. You can see that in January, we had the lowest unemployment ever measured on the Bureau of Labor Statistics in the United States at about 3.4%. Everyone that's employable is currently, and that wants to work, is currently employed. And for the first time in our country's history in the past few months, we have way more jobs open than current folks looking for jobs. In fact, there are 2 jobs open right now for every single person looking for a job, which is just crazy. In healthcare, our dynamics are even more dire. You can see on the right-hand side here, this basically represents vacancy. Healthcare has the highest vacancy of any industry outside of retail and food service. Job openings, it has the highest number of job openings right now of any industry. We have over 2 million job openings in healthcare. And we continue to add jobs, or open jobs at least, at a startling pace. In January, we added almost 60,000 new jobs. And just to give you a little bit of a benchmark, prior to the pandemic and even into the pandemic, in 2021, the average number of jobs posted per month was about 9,000. So the number of postings is going gangbusters. We can't fill our openings because there's a massive workforce gap right now. And so that's why we have the highest vacancy of any industry. Now, the job is bad overall in the US workforce. It's worse in healthcare than almost any other industry. And we exist on the West Coast. And so I put a couple of charts in here that show you a little bit more about our dynamics. And then this is really just a setup of the burning platform about why the need, in addition to COVID. You can see on the left-hand chart here, this shows basically per capita how many health professionals exist in each of the states on the West Coast. We're very challenged. We have some of the fewest per capita positions like nurses. And because of that and other dynamics, the wage rates on the West Coast are very high compared to other parts in the country. And you can see that here. Total expense in the Western states was up by 26% in 22 versus 19. That's 26% increase in wage rates across just 3 years. In 4 of the top 6 states for the highest nursing salaries, you can see those here. Those are the 4 of the 7 states that Providence is in. We're also in 4 of the 7 most highly represented states, et cetera, et cetera, et cetera. It's hard on the West Coast. And so this just highlights some of the burning platform that really necessitated a different solution for Providence.
Hey, Greg,
So
let me just jump in here real quick, because every single person on this call is more than likely dealing with a major talent imperative right now of what you've just set up for Providence and your own industry. And so, folks, I can't stress enough how I think it's important for you to flex your minds as much as possible here because of what Greg is about to share of how they're approaching the realities of where their business is. And Greg, I know you'll temper and you'll set me straight if I'm wrong here, but folks, just to put in perspective some of the additional burning platform here for Greg, according to the American Association of Colleges of Nurses, they're projecting a need for new nurses of over 200,000 more new nurses every year, just in the United States, through 2026. But Greg, what I was astounded to learn, I found that when I was presenting to one of our other hospital system members, their board of trustees this past summer, what I learned from that CEO is there's a tremendous demand for people wanting to get into nursing, but there are so few nursing faculty that's available. And what I read is that nursing colleges turned away 80,000 applicants in 2019 and 20, just due to lack of faculty. So, I mean, you guys really have this major platform here, and I challenge others to think about it that way as well. So.
Yeah, you hit the nail on the head. I mean, in addition to what you just mentioned, there are all kinds of local rules and governance that restrict the number of nursing students that can get in those schools, even if they want to your point. It's not just about the nursing faculty, which is a major issue, but to put it in perspective, in 5 years, the projections are that we're going to be 2 million nurses short on a baseline need of 6 million, which means we're not going to have 33% of the nurses that we need to provide care for our communities. We're already in a nursing shortage right now. It's going to get way worse. Across industries, that dynamic exists at a little bit of a different scale. You guys probably know this, but the US birth rate hasn't been replacing the US population since the 70s. In fact, we had the lowest workforce growth last year that we've ever measured since the BLS started. And it's going to get worse before it gets better. In fact, in the next 10 years, the BLS projects that the workforce is going to decline by 3% versus grow. It's the first time ever in US history since we've been measuring it, then that's happened. And it's because of those birth rates. It's also because of a couple of other macroeconomic factors. I hate to say it this way, but as more of our aging population passes away, that death rate is increasing significantly. The birth rate's decreasing significantly, and immigration that used to fill in the gap has basically come to a standstill through the previous administration and now through COVID. And so there's some pretty massive macroeconomic trends. that have me, frankly, having a little sweat bead on my forehead every time, I see an HR professional say, "Oh, don't worry, after the pandemic, a lot of these problems are going to go away." Well, I don't think we're reading the same kind of data, because for the next 20 years, we're going to have less and less talent to do more and more work. And so, as my colleague at Providence likes to say, especially with respect to the nursing shortage, but really all of our workforce in healthcare, these are the good old days. And so, that frankly makes us want to think a little bit differently about how we do the work. You can see on our next slide that we have some of the same strategies that I'm sure all of you do. We want to inspire our workforce. We want to develop our workforce and accelerate that. We want to enable our workforce so that we ease their way, so that they can be their best every single day. And we have a lot of innovation in that space. But if we do all of that really well, better than anybody else, it's going to solve 10% of our workforce problem in the next 5 or 10 years. And so that's why we put a lot of eggs. Like I said, I can talk for days and days about all the innovative things that I'm incredibly grateful Providence is helping to resource in the inspire, develop, and enable space. We want to ensure in the develop space that, for instance, we have offered debt-free education to all of our caregivers. We want to show you that if you're at minimum wage, we can provide a 6-figure salary to you in less than 6 years with our accelerated development programs. We have lots of great stuff there, but it's not going to solve the workforce challenge that you just outlined and that I outlined, Kevin. So that's why we need to transform the work. And that's really the topic of the conversation today. There's only one more slide and the rest of it's conversation to make sure that we're really bringing it home for folks. And frankly, taking some great ideas from others so that we can learn from them as well. But the next slide, this slide that you have up here, really talks about what we mean when we say that we want to transform the work. These 4 Ds are not mutually exclusive, and we love alliteration. So we made them into 4 Ds, but this is the 4 Ds of work transformation. And, I want to thank innovators like John Bordeaux, who recently wrote a book, Work Without Jobs. I know he's a friend of the court. I want to thank innovators like the folks that wrote the Inside Gig. There are so many really great inspirational thought leaders out there. And really all we're doing is trying to take their incredible inspiration and bring it down to pragmatic examples of where we might be able to apply some of those things. And so they use in their book, Robin and John, different words than we do. But primarily, they're talking about a lot of the same kinds of things that we talk about when we say talk about these 4 Ds. The first one is deconstruction. We ask ourselves what parts of each role can be done differently to increase the joy of practice, add capacity, or improve quality, cost, or experience of care. It's also more affordable, but we're doing these things for our caregivers. Right now, healthcare has the highest burnout rate of any industry. Over half of our workforce says that they want to quit in the next year because of the stress and burnout right now, primarily based on capacity issues. And so when we talk about transforming the work, it's for our workforce, not so that we can do our jobs at a more affordable rate, although that is a side benefit. The second D is digitize. How can we use technology to ease the way for our caregivers to enable them to do more of what they love and are called to do? Just to give you a benchmark, over 30 or 40% of the work that nurses currently do, and remember, I'm using nurses because they make up about 1/3 of our healthcare workforce, and we're going to have one of the biggest routes in that job category. About 30 to 40% of what they do, they say is below their license, meaning somebody else could be doing it. We could automate it. We could be doing it in a different way. Or we could just take it off of their plates completely and stop doing it because it's an antiquated way of working. And so we want to digitize some of that work. We also want to think about deployment more effectively. In healthcare, unfortunately, we typically across the industry have a very high rate of attrition. We have very high skilled professionals, and then we also have kind of entry-level jobs or low-skilled professionals doing a lot of the work. And so we need to think, frankly, about how we utilize our workforce almost like a supply chain to ensure that we can predict the needs and that we can staff effectively to those needs in a dynamic way. And so that's really what that deployment's all about. There's a lot of waste in how we deploy our talent because we use, in some of our hospitals, pen and paper to do nurse schedules, for instance, which we don't do anymore at Providence, but we were using 5 years ago. And then the last one is to diversify. This isn't diversify in the typical sense, although we're very committed to DE&I and making sure that we promote an inclusive culture where everyone feels they belong. However, this means that we want to diversify our sources of talent. We know that we're not going to have enough talent based on the population dynamics and the development dynamics that you described earlier, Kevin. And so we need to look to new sources of talent in order to make sure that we have enough folks to care for the communities that we're in. And so just to take this one click deeper, and this is the last slide, on the right-hand side, you can see some examples around those 4 Ds and how kind of pragmatically we've woven some of that vision or strategy into real work. And so at the top of in the middle of the chart, you can see some potential components of nursing roles. The first thing that we did is to deconstruct the nursing role. We started with nursing again, because it's one of our roles that takes the highest amount of capability, a long time to develop, a long time to train, and we're gonna have one of the biggest gaps there. And so we basically broke the nursing role down into very small component parts. We did this first during the pandemic because we just didn't have enough nurses to take care of our communities. And so we said, all right, let's look at the skills, abilities, tasks that nurses do and ask, how can we do those tomorrow in different ways? Or who could be doing those tomorrow that isn't doing that today? And frankly, we looked at our administrators that still have nursing licenses that we might be able to utilize. We looked at administrators that could be doing parts of nursing jobs like checking people in or checking up on patients or doing simple assessments. Because we were so short of our clinical staff. And so we took that opportunity to break down the nursing job into the component pieces, assessing how the work was being done, where the work was being done, and by whom the work was being done. And so that allowed us to redesign some of our work processes to match skills with tasks versus specific jobs. We haven't taken it all the way to the extreme of having only project-based work, but that's a big idea question we ask ourselves every day is how could we get closer to that aspiration? We're using virtual work and flexible staffing models. Our clinical staff rightly asked after we sent 20,000 folks home from an administration perspective in 2019 when Providence saw the first COVID patient, why not us? Why can't we do some discharge work from home? Why can't we provide a virtual staffing unit for nursing to ease their way? Same thing with medical assistants. And so we are actively piloting and scaling virtual nursing units in order to offset some of the demand issues. And then, of course, I said these weren't mutually exclusive, but part of that deconstructed work can be digitized. You know, a lot of the work that nurses and nursing managers are doing today can be automated or done in different ways through digital technology. We are using technology in that middle column there to do everything from.
Hey,
sorry,
Greg, yeah. Before you move on to digitize, the second D, on the deconstruction, I've shared your story that, we did a case study with you when you first shared this story with us. And I know it's also in John and Robin's book. And I've been sharing it at a lot of presentations I've given to our members and otherwise. And one of the things that struck me about it was you mentioned the administrators that still have, some of them former doctor, former nursing licenses, and can do some of the tasks that are in that middle box there, but also the simple assessment, temperature, blood pressure checking, and checking in on stable patients, which by definition, they're labeled as stable. I found it interesting that you could also go below the nurses to maybe receptionists or whatever you might call folks in those kind of roles. And with minimal training during a crunch period of time, they can do some of those tasks. I mean, we've all seen that, especially, during the harshest times of COVID when hotels were first reopening. The receptionists at the hotel were taking our temperature in order to allow us into the hotel. They had I would assume, minimal training in order to do that with the new temperature guns that we have today. So say a little bit about that you both looked at, up the management chain for potential pool of talent that could be deployed for some of these tasks, but also down the sort of skill chain as well.
We did. I mean, in the heat of battle in January, February, and the first couple of quarters of COVID, I mean, we were taking very highly paid administrators and trying to figure out how to put them on hospital floors, right, in order to do some of the work based on that skills analysis that we deconstructed from the nursing jobs. That's obviously not practical long-term. However, it really made us think differently about the different components of nursing jobs that could be done in different ways or done by others. Today, the folks that check you in can take your temperature versus having, we hired hundreds of temperature checkers in our hospitals at the outset of COVID and said, oh my gosh, we just added like 300 staff to our hospitals just to check temperatures. Why are we doing that? That lasted for about 2 weeks until we figured out the fact that we could combine that specific task into somebody else's task jar to help ease the way of our patients and our health system. And so that created, a big idea. We were talking before this seminar about some of the big ideas. I'm not sure I'd call them vision points yet, because whenever I have a vision, I like to put strategy, actions, and accountability against it. But I just call them big ideas, and we created a lot of big ideas like, and we'll talk about this a little bit later maybe, but what if we could turn every one of our 120,000 jobs into a gig job? What if we could completely eliminate all certifications and education requirements from every single job in healthcare? What if we could completely deconstruct jobs and have people flow to the work based on the projects, based on their interest or skills? What if we could turn our entire development system into something that develops skill stacks versus, forcing people to go back for degree programs that are kind of antiquated, where maybe 20% of what they're learning is relevant to the marketplace of tomorrow. And so what, the specific question that you asked around deconstructing jobs and putting, and having administrators do some of the work that clinicians were before really helped us. Frankly, it forced us to think differently about how and who was performing the work in ways that, our incredibly innovative CNO, Still Trepanier, and our administrators are continuing to innovate based on. It basically took a lot of things we've been talking about for 5 or 10 years and trying to implement, but kind of slowly along the way, doing a lot of pilots, trying to have proof points, figuring out how we were going to invest, and it created immediately a change-ready environment. And so through kind of the horrendous COVID situation and the chaos, it created a very healthy change-ready environment that allowed us to accelerate the pace of change and try lots of new things. Former executive here from, I think he's back at Amazon now, Aaron Martin, who's used to be in charge of our digital strategy, brought one of their philosophies, which was fail fast. Learn to fail fast. Try lots of things, fail, admit that you failed, pick the things that worked, and move on fast. Don't spend 2 years doing a pilot to find out it really didn't work, but you wasted a lot of resources. And so we applied that concept to our workforce through COVID.
Hey, Greg, just curious, any major strategic shift as a business requires a commensurate shift in culture and the way leaders from a mindset and a capability standpoint need to lead in order to support that type of culture. Can you talk about any type of culture? What were the major cultural implications here at Providence in order to start doing what you're talking about here?
Yeah, I think that there are 3, I think. And I think what makes a high-performing culture today isn't that much different than what made a high-performing culture 20 years ago. I think how we execute against those things and what's first, second, and third might be, in different orders today. But the 3 things I'll say that really shine for us, that are helping us, frankly, retool and refocus our culture, but also has us looking at our value proposition, our caregiver or our employee. We call all of our employees caregivers. Our caregiver value proposition a little bit differently are these 3 things. Number 1, flexibility. I like to say that flexibility is the new engagement capital. If flexibility isn't part of your core value proposition for your employees, thank you. I'll have an easier job recruiting them into Providence. There's lots of studies, many of them that you've published at I4CP, that show that folks will take a little bit, even less pay or different work rules for more flexibility. We don't want to pay them less, but we do want to offer as much flexibility, radical flexibility as possible, not just for our administrators, but for our clinicians. Every time I read an article about, another company pulling people back, 4 or 5 days a week, like I'm not, usually 3 or 4 days later, they publish another article saying, oops, sorry about that. Tesla did that and Twitter did that. We're bringing everybody back. Oh no, sorry, we didn't mean it, because they realized that the culture dynamics have changed. So flexibility is one. The second one is agility. How can we move fast, not spend a lot of time in decision-making? I love the quote, vision without execution is merely a hallucination. There's lots of different variations of that, but eventually you got to actually do something. That's why I picked that song, A Little Less Conversation and a Little More Action. If you actually start doing stuff, you can find out really quickly what works and what doesn't, and then just stop the stuff that doesn't. It's okay. No harm, no foul. So agility, I think, has risen in the priority list of what we need our cultures focused on. And then the third one that sounds kind of soft is collaboration. And, a lot of the work that I'm talking about here today was done with 50 other people in the room, brainstorming, figuring out how we were going to implementing it and giving us feedback. I mean, from almost day one, our clinicians set up a daily huddle, just like we had in our hospitals prior to COVID, on workforce management, on resource management, because we didn't have enough ventilators, masks, or gloves, on what the COVID rates were in our hospitals and how we could deal with those things more effectively. It's basically a stand-up for 20 minutes every day. And there were calls like stand-ups with 300 people on them, administrators all the way down in every hospital. And there were stand-ups with 25 people on them dealing with specific issues. Those helped us through the vaccination process and the vaccination requirement process, and we've kept some of those stand-ups still today to help us to continue to innovate and keep people aligned. And so I think those are the three things that come immediately to mind about enhancements to culture: would be flexibility, agility, and a better, more effective, coordinated, collaborative environment.
Hey, Greg, before we move on to your other 3 Ds here, beyond deconstruct, there were a couple of questions, related ones in the chat. John asked, and they're both around upskilling more, I would say, in the medium and long term, as opposed to the story you've told so far was very much dealing with an acute issue around deconstructing the work to help with the nursing shortage. But if we look at upskilling for the medium and long term, John wondered, what are you doing at Providence to upskill and maybe even provide direct certification or whatever it might be for certain roles that you're going to need in the coming 1, 3, 5 years? And then Marissa asked, are you perhaps not doing that as much internally, but through partnerships with schools, universities, community colleges, et cetera? What's your connection with both the outside and the inside sources of upskilling, I guess?
All the above. As I mentioned, we're primarily talking about the transformation of work, but we're also going all in on accelerated development. We form partnerships with folks like Dignity Health and Common Spirit to kick off a new school for health professions. We partner with organizations like Guild to offer more affordable, accessible education to our internal folks. And we've tripled our investment in our own workforce development to, as I mentioned, I'm not sure if this tagline is going to stick because it seems too long to me, but how can a minimum wage person get to 6 figures in 6 years? How can we take a warehouse worker that works in another industry right now that might be getting laid off because of automation and show them a path to a 6-figure job in nursing or administration in less than 6 years in development that we'll pay for to get you there? The primary difference for us and the difference maker, I mentioned that we're investing in partners to help the education process. That's really important in today's reality, but we also are putting a lot of our chips into developing what I called earlier skill stacks, identifying the skills and capabilities that people really need to do the jobs today and well in the future. And only training them on how to do those things, and frankly allowing them to, and identifying in today's world the skill stacks that are needed for the specific jobs that exist or the jobs that are going to exist in the future, and allowing them to pick and choose so that they can be in charge of their own development using components, using skills and capabilities that they gain versus degrees. I'm going to say something super crazy that I don't completely believe. I do this a lot, and then people give me some body blows, but it helps us to think differently. How many of the courses or how many of the hours of your 4-year degree, or I have 2 master's degrees and started a PhD, of all that education, how much of it actually contributed skills and capabilities that are necessary for the job I have now and for the job I have in the future? I would say, especially for the types of jobs that healthcare has today, which are very skills and capabilities focused, less than 100%. I won't give you the number that I really think, but less than 100%. But imagine if it was 20%. We wasted 80% of a person's time and money. They're spending $20,000 a year, some of them in 4-year colleges. And I still don't understand, frankly, why we haven't banded together and completely democratized the education system, allowing everyone to complete if you want to get a degree, complete the first 2 years online for $1 a course. How different is Comms 101 at Harvard than it is at a community college down the street? Probably not that different. And do you need it for your nursing job? I don't know. And so sorry for the long diatribe, but all of that to say, we're partnering very heavily with folks to build schools of health profession, to utilize the education system, to pay for the education for our caregivers. We don't want them to spend one dime to develop themselves. But the real future is in I think I saw John pop up and say, stacking credentials or stacking skills or stacking capabilities. That really allows the acceleration. That's why I'm embarrassed to say 6 and 6, because I really think it could be 6 and 3. If we get really good at stacking credentials or stacking the skills that you actually need. And oh, by the way, then you're going to be able to say, oh, those are the skills, the stackable skills that I need to be an HR executive or a finance executive or, become a doctor. Okay, now I know what they are, and I can start having development plans that contribute to the skill stack for the 3 or 4 different paths I want to take in my career versus saying, now I'm going to go get the next 6-year degree because this is the specific job that's going to help me with.
Well, you've got a couple of upvotes from Becky and Marissa in the chat, whether it's 6 and 3 or 6 and 6. They're thinking that it is a short enough tagline. So I think you're onto something there.
I appreciate it. I'm crowdsourcing taglines.
Yeah.
Please feel free.
Keep the questions coming in and the comments coming in the chat, folks. But for now, let's move on so we cover the other 3 Ds. I'm just looking at the clock. We got 20 minutes left. So Greg, we want to hear about Digitize next.
Yeah, thanks. Appreciate the opportunity. So, Digitize is pretty simple. It's really about utilizing technology differently than we ever have. To me, AI and ML, machine learning, and AI are they were pipe dreams 20 years ago. Everyone talked about wanting to utilize them, but we weren't really using them productively or pragmatically. And today we're deploying technology in almost every aspect of our work, from assessing patients before they walk in the door, to monitoring patients, to helping to provide solutions, to connecting with patients to get them to utilize their medication more effectively at home. In the workforce space, we're doing that too. We're using prediction models in order to staff more effectively. If we know it takes 3 months to get an experienced ICU nurse on board, why are we waiting till one retires in order to post requisition, allowing for 3 months of vacancy that either needs to be filled with a more expensive agency person or that stops us from being able to provide clinical care. And so we're using a ton of automation and predictive modeling to staff more effectively and to post requisitions before we even have the need. We're also using smart schedules. And so, in the old world, a nursing manager might spend 2-3 hours every 2 weeks doing scheduling. Those schedules were pretty inefficient, not based on very good projections of community needs, patient acuity, volume demands, or our caregivers' desires about the schedules they wanted to work. And so we've automated our scheduling process with technology that we hope one day to be a revenue source for us, to help us to build the most efficient schedules, but at the same time, build schedules that our nursing leaders really want. And it's also allowing us to look at scheduling differently. I talked about radical flexibility before. Typically in healthcare, our schedules for nurses are 12 hours, 3 days, or 12 hours, 4 days, if you want to work a day of overtime. That's incredibly taxing, especially as our nurses age or if you have a disability. It's also not pragmatic for a working mom or dad who wants to be a nurse. And so this automated scheduling system that we have in place now allows us to do a lot of really cool things, including deploy more effectively. But it allows us to have 4-hour schedules and 6-hour schedules and almost allow nurses to choose their own. We're not completely there yet, but that's part of the radical flexibility that we're talking about, is letting everyone choose the exact schedule that they want to make, they want to work. We're also looking at different ways to automate to increase capacity by automating, sitting and automating recommendations for our nursing leaders, and automating scribing, which takes a lot of time for nurses and doctors today. Entering data into the electronic medical record. And then we're also digitizing to deploy our workforce more effectively. And so this is basically, in the deconstructed role, we're asking about what parts of the role can technology help us to do more effectively? What parts of every process can technology help us to do more effectively? And, one of my friends, a partner from McKinsey, likes to say, everyone's worried about automation taking over your job. It's not going to take over your job. It's just going to take away the dull and the dangerous. And that's not the holistic picture. But that's kind of what we're doing with automation, is trying to figure out how to make sure that we take part of that 40% of work that nurses really don't want to be doing anyway, and automating as much of that as possible.
There's also, Greg, it's such an interesting opportunity for everyone to learn and borrow from different industries. One of the things that we've been seeing for over a decade is just, greater desire for control. And what we know for sure from all the data is predictability when it comes to scheduling is so critical for certain people, especially, that are dependent on, their paycheck, living paycheck to paycheck, if you would, and empowering them to actually make decisions. And I just wonder, are you learning from other sectors like retail that might be allowing people to actually swap shifts with someone who is equally certified or trained in a given role, but they can switch without having to get a manager approval or doing things like that? How are you thinking about that?
We are, we want to be the best in healthcare, but we also want to make sure that we're looking to other industries that frankly have different environmental circumstances, or they're just ahead of the pack. We're very heavily regulated. It's impossible, at least right now, to deconstruct the jobs completely because they require special certifications in a lot of cases. But we're looking to other industries that don't have some of those barriers to ask ourselves how we can push the envelope. And so, IBM is a great example. Nick, I know Nickel, the CHRO there, of deploying a pretty great internal talent mobility system that's kind of akin to the skill stacks that I'm talking about now. We have friends in supply chain companies that are helping us to think about how we can apply supply chain tactics to our workflows. And so, one of the things that makes Providence pretty innovative is, 10 years ago, our CEO had a vision and started both lifting the most innovative up from within healthcare, but then hiring lots of folks from outside of healthcare. Almost every administrative position that reports to our CEO is from outside of healthcare. Our chief digital innovation officers from Amazon, our CFOs from T-Mobile. I could go down the list. I'm from the big bad defense industry. I like to joke around and say we were saving lives in different ways over there. But lots of creative thoughts from different industries. And then I try to stay as networked and do stuff like this in order to maintain those connections with folks who have really creative ideas. We might not be able to implement holistically or today, but can help us to modify our vision points or our big questions. And so that's a really good insight, Kevin. Thank you for that.
You, Greg, you've said so much in such a little bit of time here. And I think this slide is probably so helpful to so many people on this call. One of the things I remember you sharing before, and if we can get to the Diversify here, one of the things that I remember you sharing back with the CHRO board was a model that we have at I4CP, the talent ecosystem integration model. And you said, oh my gosh, that was so helpful. You almost used it as an overlay when you started thinking about, different sources of talent. Can you tell people how, diversifying sources of skills and capabilities is fitting into your vision here?
Yeah, I mean, it's huge. And kudos to I4CP for that model. And, when we talked a couple of years ago and we're inspired by John's work and your work and others, it made a big difference in helping us to codify, or put together a lot of different components of strategies that we had in the past. And one of the biggest things that it got us thinking about was how to diversify our workforce. There's lots of things that we're thinking about in this space, including how to make family members caregivers. But the really exciting thing that we're moving towards, two things. The first one is, I mentioned virtual work earlier and virtual nursing units. Well, that's not only, more flexible and allows us to do things more effectively for our patients and for our current caregivers, but it also allows us to open up access to markets that, on the chart earlier, I showed that on the West Coast, we have a massive talent drought compared to the middle of the country. Well, some of our states are nursing compact states, which means if you have a license in, I don't want to make it up and have my CNO yell at me, but if you have a license in state A, then you can perform care in state B. And so with that in mind, we're taking our virtual nursing units today that are in Texas, supporting a Texas hospital, and asking ourselves, what if we could do that from Alabama or another state that doesn't have the same talent gaps that we do on the West Coast, not just for nursing talent, but for medical assistants, administrators, and everything else. The second really crazy idea that I'll share, I'm not sure if I've shared more than 2 crazy ideas, but another crazy or big crazy idea that we're thinking about is, what if we started with the concept that every job is a gig job? What if we have no more employees? What if everyone gets to choose their own shift, their own workplace, their own boss at their own pay rate? And we're pushing the envelope on that. Today, we're deploying pieces of it. We're allowing people to choose some of their own schedules. We're partnering with an external vendor called CareRev to basically create a gig economy of external caregivers that can supplement our internal caregivers using the same scheduling technology so that we can fill in gaps externally that we can't meet with our internal workforce, allowing folks to pick their own shifts at their own pay rates with our external folks now. And so we're merging our technology to frankly blend the external talent base with the internal talent base to do a lot of these things in this chart that you're showing right now. And one of the inspirational things that we took from this chart was the gig workers and freelancers. Healthcare has had that for a long time, but typically our gig workers and freelancers, our agency traveling nurses, make 2 times what our current FTEs do. And during the pandemic and the workforce crisis, even more specifically last year, they at one point were making 3 times as much as our internal workforce were. And so, a lot of healthcare systems ran out and said, we want to go out and create our own agency so that we eliminate some of the middleman's cost. And I'm sorry for my healthcare peers. We are also looking at that as one potential strategy. But for me, whenever people use that as their only strategy, I say, man, the 1980s called and they want their strategy back. The new strategy is trying to figure out how to create more flexible gig economy work for your internal caregivers and for your external community members, so that you can have a system that takes advantage of the talent holistically, versus decreasing a little bit of the agency / travel nursing cost by starting your own. And it's actually not too far. It's one step in the right direction, basically creating your own float pool using internal and external talent.
Just listening to you, Greg, I mean, what you're talking about is a whole different, and what we see is a different twist on the term sustainability. Sustainability in so many contexts is viewed as just environmental sustainability. But what you're talking about is for Providence to sustain as an organization, you have to, what has to be true in order for that to happen? And you're looking at the reality of the talent situation, the economics, et cetera, and saying, these are the things in order for us to sustain that have to be true. And you're really going deep and disaggregating those. It's an important question everyone should be asking, but it takes tremendous discipline.
It does. And it's, we're for the last couple of years, we've been talking about sustainment, but really it's also about thriving. I mean, these strategies, some of them are based on helping the healthcare industry out of the hole that we're in right now. I mean, almost every nonprofit health system lost a ton of money last year on the market and through operations based on labor cost increases and lots of other things. And so we are talking about sustainment, but this is also about thriving in the next new economy, in the next new set of workforce challenges. And, someone asked a really great question in chat, and we're also struggling through this ourselves to think about it, about how do you maintain your culture, your esprit de corps, your values, if everyone's a gig worker. And so when I say, can everyone be a gig worker? To me, that's like a fence post. That's a big idea that helps us to think about radical flexibility and new and different ways. It doesn't necessarily really mean, at least for the next 5 years, that, we have 120,000 workers today and we're going to put them all on the street and they're all free agents. But what it does mean is, what are the benefits of the folks that like to work at companies like Uber? I mean, they're basically freelance gig workers. They like to get paid every day after they do a day's work. Can we implement a pay system for especially lower paid caregivers like MAs and CNAs, where they get a paycheck at the end of every day for the amount of work that they did? They also can work their own hours. Can we do radical flexibility in our scheduling so that our nurses and MAs can choose their own schedules? And so it's more about how do we mix internal talent availability with external talent availability to ensure that we can fill all the shifts and don't suffer from a 20% vacancy rate that doesn't allow us to care for our community members. And so we do have a lot of work. Our mission and our values are at the core of who we are. So there's probably not a day, at least in our near-term future, where we really don't have any caregivers internally. It's really about applying the concepts of the big ideas to make work as caregiver friendly and community friendly as possible.
Hey, Greg, we've just got a couple of more areas we want to explore with you with very limited time here, but just curious, how did you approach your union and your union-based workers with this concept here?
Well, I mean, we pilot a lot of things in areas that are not organized to see if it works. And then if it does work, we get the users, the folks that it benefits. Remember, for us, all of this is to benefit our caregivers. It's to increase capacity. It's to lower their stress and burnout by ensuring that we have more capacity to serve them and bring the joy of practice back into healthcare. And so the second thing that we do after we pilot it and have some success is we ask our nurses to be our biggest advocates with their counterparts to help them understand how it's increasing capacity, bringing joy back in work, helping them to spend more time in clinical care with their patients. And we utilize the ongoing relationships that we have with labor. You know, we're a system of separate employers. And so not every relationship is equal across our family of organizations. But we have a lot of really productive relationships with labor because we're trying to get to the same outcomes. We want productive work environments for our caregivers. We want to create better, more healthier context for those caregivers. We want to contribute to bigger societal change to make sure that we create a healthier society so that we can improve the health of the communities that we're in. So many of the outcomes with organized labor are the same outcomes that the health systems are trying to achieve. Some of the methods and ideas about how to get there are different. And so we typically try to partner with them over the long term, talk about the outcomes that we're trying to create, and then figure out how much flexibility we can work into the system that we currently have. You know, none of this is going to mean that we need less workers, less caregivers, providing patients for caregivers. If we're doing this right, we're expanding the workforce, not detracting it. And so a lot of some of the typical barriers that would come up through conversations and with an outcomes focused are able to be alleviated, especially with a focus on the nurses or on the clinicians themselves. We're not doing this to benefit the company. We're doing this to benefit our communities and our workforce.
Well, the chat says it all. I mean, there's so much conversation going on, Greg. So this topic and what you're sharing is really resonating with the audience. Now we're going to have you put your advisor hat on, and you're going to provide guidance to the audience if they want to start now, or how to, where should they start? How should they approach this if they want to go down the path you are?
I mean, I give everybody on this call, because they're all I4CP members or interested parties, a lot of credit. They're probably doing a lot of this already. What I'll say, a couple of things that have helped us to be more successful and help to accelerate change than maybe where we failed in the past are, number one, it sounds so basic, but you have to be able to articulate the compelling need. I know it sounds crazy. Everyone feels a workforce crunch right now. Something like 90 CEOs say workforce is their top challenge or priority, but you need to be able to articulate the need in a way that doesn't have people thinking that just giving people more hugs or recognition is going to work. That's not going to fill the workforce gap. And I'm saying that tongue in cheek, even though a lot of our efforts are focused on providing a healthier environment for our workforce and inspiring them more, but it's not going to fill the workforce gap. And so you need to be able to articulate the real issues and the real dynamics that are at play, so people just don't rely on the same 80% of the solutions that we've been deploying for the last 20 years, which is kind of the knee-jerk go-to. Secondarily, I think we've got to be really good as HR professionals, as business professionals, to articulate the outcomes that we think that we can drive for our communities or customers, for our employees or caregivers, and then for the business. I don't think we do a very good job of it in HR, talking about the outcomes that we're going to create in ways that our business leaders or our clinicians or are the most influential stakeholders, our boards, can really understand and can get behind. I love talking about culture like Kevin does. I love Kevin's book. And one of the things I really love about it is that he talks about how great cultures lead to high performance in ways that business leaders can understand. We need to be able to articulate the outcomes in ways that business leaders can understand, and then execute the hell out of it and claim success. You know, I think HR a lot of times is in the weeds of so many difficult processes. We don't come up for air and say, we said we were going to do this. We tried it. It didn't work. We stopped it, or we tried it. It worked. And here's the result that we said we were going to get, that we measured. Check out this result that we said that we were going to get, that we measured. Let's go do some more of that. And so it's super simple. I don't think that there's a lot of secret sauce to it. But I mean, we have to take our HR hat and put our business hat on first in order to articulate the need, claim the outcomes, commit to it, go do it, and celebrate it in ways that other stakeholders like your CEOs and your boards can really get excited and get behind. Every time one of my own caregivers comes and says, Greg, I couldn't get investment for this development plan, or my resources got cut for this, I either say, use it as a creative opportunity to do something differently, or did you really sell it as effectively as you think you did? Because for the most part, if you're telling the business that you can radically change the outcomes that you're achieving for your customers, your communities, or your caregivers, very rarely have I been in a situation where we've been told, no, don't do that, even if it takes a little bit more investment.
Greg, thanks. What you just said really brought to mind this. So for I4CP members on this call, next week, we're going to publish a document called CHRO and Corporate Board Alignment. And one of the key findings, this came from data we collected from 80 members of private and public company boards, but one of the key findings in there is that the data that the human capital data most corporate board directors get access to tells an incomplete story. And the onus on that falls on HR. And so you'll have that to look forward to. And I think it really just will reinforce so much more of what you just said, Greg. But hey, just personally, I can't thank you enough for taking time out of your crazy schedule to share back your insights. And look forward to seeing you in person coming up here soon, Greg. So thanks. And I'm going to turn it back to Tom to close things out.
Yeah, I'll obviously second that. Thanks so much, Greg. Great to hear from you directly. I've known parts of your story from these past few years, and like I said, leveraged it many times, but great to hear so many more details from you. And as Kevin said, the chat's been blowing up with lots of comments, kudos, and gratitude for all the strategies you've been sharing. So thanks again, Greg. Just want to remind folks that our next Practices Now conference is at the end of this month. We're now in March. So if you haven't registered yet, pass this along to interested colleagues as well, i4cp.com/conference. Look forward to having as many HR leaders join us out in Scottsdale as you can. Thanks again, everyone. Great call, and join us again next Thursday where we'll have another great guest. Have a good week.
Thanks, everybody.
Thanks, Greg. Thanks, Tom.